Another important cause of epigastric pain is peptic ulcer disease. Actually, peptic ulcer disease is a misnomer. Peptic. Why peptic? Because previously they thought that the cause of peptic ulcer was pepsin. Actually, it is not pepsin. And let me even say it is not the stomach acid that directly results in peptic ulcer. So we have two things in the stomach. We have a very strong acid that makes the pH of the gastric cavity around 2. This is very strong acid. But in the same time, we have a very good protective mucus barrier between the stomach cells and this acid in the cavity. And it is the loss of the mucus barrier that results in peptic ulcer, and it is not the very high acid. We only have the acid as the cause only in one condition, which is Zollinger-Ellison. Peptic ulcer disease can happen in the duodenum, in the first part of the duodenum. The duodenum is the first part of the small intestine that follows the stomach. Most commonly, peptic ulcer disease happens in the very first few centimeters of the duodenum, and we call it duodenal ulcer. Less commonly, it occurs in the stomach itself, and we call it gastric ulcer. Gastric ulcers, 4% of gastric ulcers could turn malignant, and that's why when it is gastric ulcer, you need to be cautious and you need to do endoscopy. Anyways, you're going to do endoscopy to diagnose. There is no way to differentiate if this peptic ulcer in the duodenum or in the stomach. No way to differentiate based on symptoms. You need to do upper endoscopy. The two most important causes, what can cause peptic ulcer disease? The two most important causes that will result in peptic ulcer disease are the causes that affect the mucus barrier. Number one is H. pylori. H. pylori. This is the most common cause. The most common cause is H. pylori, Helicobacter pylori. It's a bacteria that invades the stomach and will dig holes into the mucus barrier and will damage the gastric cells, and now you have a defective mucus barrier, and these damaged gastric cells are going to be irritated by the stomach acid, and the peptic ulcer will result. The second commonest cause of peptic ulcer disease are NSAIDs. NSAIDs, the use of non-steroidal anti-inflammatory drugs, and NSAIDs are available over the counter, and people use NSAIDs for whatever reasons, headache, backache, knee pain, whatever. So a lot of use of NSAIDs will result in peptic ulcer disease. These two causes account for more than 99% of all the cases of peptic ulcer disease. Other rare causes, head trauma, burns, and intubation will result in what's known as stress ulcer. Crohn's disease might result in gastric ulcer also. Zollinger-Ellison syndrome, or gastrinoma, this is too much secretion of gastric acid. This is the only condition where the peptic ulcer develops because of too much acid and not too little mucus barrier. How to diagnose peptic ulcer disease? Endoscopy. Endoscopy. And endoscopy, by the way, is indicated in any patient more than 45 years of age, and per other gastrointestinal authorities, more than 55 with chronic epigastric pain not resolving. You need to do endoscopy to exclude gastric malignancy. Endoscopy is the only way, as I said, to distinguish between duodenal ulcer and gastric ulcer. Let me give you some physiological information about how do our stomachs, how does the stomach manufacture acid and releases it to the gastric cavity. We have three stimuli that can stimulate the stomach to make acid, to stimulate the parietal cells to make the acid. The acetylcholine will stimulate muscarinic receptors in the parietal cells, and this will increase the production of acid by the parietal cells. Also, gastrin hormone will stimulate these cells to manufacture acid, and also histamine will stimulate histamine 2 receptors to stimulate the parietal cells to manufacture acid. So now we have three stimuli for the parietal cell to make an acid: acetylcholine, gastrin, and histamine. That's why when I give H2 blocker, when I give histamine blocker, ranitidine, famotidine, histamine will, this channel is going to be blocked, and this will affect the ability of the parietal cell to manufacture acid, but still the cell will respond to gastrin, and still the cell will respond to acetylcholine. When the parietal cell makes an acid, in order for this acid to exit from the cell into the gastric cavity against the chemical gradient that is found there, it has to be pumped effectively into what's called the proton pump. The proton pump is the pump that pumps hydrogen into the stomach cavity, that pumps acid into the stomach cavity. So think of the proton pump at the final exit, that any acid formed due to any stimuli coming to the parietal cell will finally use this gate. So if you block this gate, no acid will pass into the gastric cavity. That's why if the patient was taking H2 blockers and the symptoms of peptic ulcer were not improving, then proton pump inhibitor will do the better job, but not the other way around. If the patient was already taking proton pump inhibitors and he was not responding, do not get back to H2 blockers, because H2 blockers are weaker because they only block one receptor out of 3 receptors, but proton pump inhibitors will close the gate to the stomach. So it's a balance between the acid and the mucus barrier. To develop peptic ulcer disease is more of losing the mucus barrier. And that's why the 2 strategies to treat peptic ulcer disease are: first, get rid of the cause, and second, get well soon. Let me explain what do I mean by that. Get rid of the cause. What's the cause? H. pylori, kill the bug. What's the cause? NSAIDs, avoid NSAIDs. So what's this get well soon? Is it a greeting card? No. Get well soon in peptic ulcer is provide adequate healing environment. Provide adequate healing environment. Let me ask you a question. If you have a wound in your hand, do you think this wound is going to heal if you keep immersing your hand in vinegar, for example? Of course not. The same for the peptic ulcer. The ulcer in your stomach is not going to heal when you keep high acidity in your stomach. You want to lower down the acidity. So first thing for providing good healing environment, less acid. So you can use antacids, but this is kind of a weak way to reduce acids. You know what? Before the first H2 blocker was introduced to the market, cimetidine, we used to treat peptic ulcer by doing what? Vagotomy. We cut the vagus nerve going to the stomach to block the acetylcholine stimulation of the parietal cells. But now we have, of course, medications. You can start with H2 blockers. Please don't use cimetidine. It has a lot of side effects. Use ranitidine or famotidine. And these will block the histamine receptors, H2 receptors in the parietal cell, and this will help lowering the acid. If H2 blockers were not effective, let's use the more potent acid blockers, the proton pump inhibitors. And by this means, we are going to provide less acid in the stomach. We're going to provide good healing environment for that ulcer. The second way is, let's augment the barrier. The barrier is made of prostaglandins. We can just put sucralfate, add sucralfate, and sucralfate will form a paste-like layer on top of the ulcer, and this will protect the ulcer from the effect of the gastric acid and give the ulcer time to heal. But more efficiently, misoprostol. What's misoprostol? It's a prostaglandin. And the mucus barrier is made of prostaglandin E2, and misoprostol is prostaglandin E2. That's why NSAIDs will result in peptic ulcer, because the mucus barrier, the most effective protection against peptic ulcer, is made of prostaglandins. And how do NSAIDs work? NSAIDs work by being anti-prostaglandins. They prevent the synthesis of prostaglandins. So when you take NSAIDs, you cannot make prostaglandins, your stomach cannot make an effective mucus barrier, and you develop peptic ulcer. If you want to treat it, if you want to augment the mucus barrier, you need to give prostaglandins. And misoprostol is a prostaglandin, but the point is, too much misoprostol or too high of a dose will result in severe diarrhea. Let me start with the case study, some key features in our peptic ulcer disease case study. This is a 56-year-old male who presents with a 4-week history of increasing upper abdominal pain, epigastric pain. The pain is burning in nature, localized into the epigastrium and not radiating to the back. The patient has been taking ibuprofen almost daily for his knee pain. Very important piece of information there. He also takes daily 81 milligrams aspirin for his heart, and the endoscopy and the tests showed the following. Endoscopy showed normal appearing esophagus, but 1 centimeter gastric ulcer with evidence of recent bleeding, and the rapid urease test was negative. This means that the cause of peptic ulcer here was not H. pylori. Of course, the cause is very obvious, the use of NSAIDs. The CBC showed normal white blood cell count and mildly low hematocrit. Questions 1 and 2. They are asking about the contributing factors to the patient's peptic ulcer and what was the most significant one. Of course, the long-term use of non-steroidal, very important one. Cigarette smoking contributes but does not cause. Cigarette smoking will contribute to peptic ulcer, but cigarette smoking does not cause peptic ulcer. And stress also can contribute to peptic ulcer, but stress alone does not cause peptic ulcer. What is the most significant contributing factor? It is the use of NSAIDs. It is the use of NSAIDs. Why might the primary care provider have inquired about possible shortness of breath or exertional chest pain? Very important question for a patient with epigastric pain. You have to verify that it is not coming from the heart. The pain in the epigastrium could be coming from the heart, and you need to verify that you don't have an ischemic heart disease here. Sometimes acute myocardial infarction can present with acute epigastric pain, and myocardial ischemia, chronic stable angina can present with chronic epigastric pain. So ischemic heart disease from an obstructed coronary can result in breathing problems or chest pain with exercise, so you want to verify that the patient does not have shortness of breath coming from his heart. And this patient in particular has a very positive family history for ischemic heart disease, and therefore an personal history of hypertension. So therefore you want to verify that. How to verify that? An EKG might be ordered for this patient. Question 6. What is the significance of the white blood cell count? Why do we need to do a white blood cell count for patients with peptic ulcer disease? Well, because if the white blood cell count was elevated, then we might think of perforation of the ulcer. Perforation of the ulcer. The ulcer is too deep that now it perforated the whole thickness of the stomach wall, and now the stomach wall or the stomach cavity is open to the peritoneal cavity, and this will result in peritonitis and acute abdomen. Question 7. What's the significance of the low hematocrit? What's the significance of the low hematocrit? This is a bleeding ulcer, and the patient is losing tiny amounts of blood every day, and this will result in iron deficiency anemia. And also the heme positive stool will confirm that there is blood in stool. Question 11. How are you going to manage this patient? An 8-week regimen of a proton pump inhibitor. Any proton pump inhibitor taken orally should heal this gastric ulcer. And you need to follow up with the primary care provider and reevaluate with endoscopy in 2 to 3 months. Very important to do endoscopy and follow up endoscopy in gastric ulcer, because gastric ulcer can turn malignant in 4% of cases. And of course, the patient should strongly be encouraged to use acetaminophen for pain and stop using NSAIDs. And the patient should also be strongly encouraged to reduce or completely stop smoking. Always know that you will never, under no circumstances, you will never advise for increase smoking or keep smoking. Always your advice to your patient is stop smoking. Encourage the patient to stop daily aspirin, at least until the ulcer has healed. And finally, the patient's blood pressure was also high, and you need to manage this too. It was high at the time of physical examination. Well, we do not diagnose hypertension based on one reading, so you might need to follow up on that to make sure if hypertension was there.